Hello, and welcome to our listeners around the world. This is the JAMA Editor's Summary, and today is Friday, January 31st, 2025. I'm Dr. Kirsten Bibbins-Domingo, Editor-in-Chief of JAMA and the JAMA Network. I'm joined today by JAMA Deputy Editor, Dr. Preeti Malani. Let's get started, Preeti.
Hi, Kirsten. This week, JAMA published 4 research articles and 1 research letter. Let's start with the Sunrise trial. We know that patients receiving unplanned or emergency abdominal surgery are at increased risk of surgical site infection. This study group explored whether incisional negative pressure wound dressings affected surgical site infection rates in patients undergoing emergency laparotomy. The 2018 World Health Organization guideline on prevention of surgical site infection made a conditional recommendation to use this technique in patients at high risk, although prior data on its effectiveness are mixed. This trial included 840 adults in the UK and Australia. Patients were randomly assigned to receive either a negative pressure dressing or another wound dressing of the surgeon's choice. The authors found no significant difference in surgical site infection rates between the two groups.
JAMA also published 2 related trials this week about care for patients with dementia. These authors examined different care models focusing on patient and caregiver-centered outcomes. The first is the DCARE randomized clinical trial that included more than 2,000 dyads of individuals with dementia and their caregivers. The authors were examining 3 different programs for dementia care: health system-based programs, community-based programs, and usual care. The health system and community-based programs were delivered by distinct types of care providers who received unique training curricula for this study. Patients were randomly assigned in a 7-to-7-to-1 ratio into the health system-based, community-based, or usual care groups. For the primary outcome, the investigators used measures of patient behavioral symptoms and caregiver strain at 18 months, and the authors found no significant difference among the different groups in the primary analysis, but did find that caregiver self-efficacy, a secondary outcome, was significantly higher in the health system and community-based programs compared with usual care.
The INPEACE randomized clinical trial also focused on patients living with dementia, with specific attention to managing symptoms and palliative care concerns. This author group created an intervention consisting of monthly calls from a trained nurse or social worker who would use those conversations to initiate evidence-based protocols to help caregivers manage patient symptoms, caregiver distress, or palliative care concerns. The investigators enrolled patients with moderate to severe dementia and their caregivers for a total of 201 dyads. Patients were randomly assigned to receive the monthly call intervention or usual care. The primary outcome was reduction in patients' neuropsychiatric symptoms as measured using the Neuropsychiatric Inventory Questionnaire, or NPIQ, that was assessed quarterly for 2 years. The authors found no significant difference in NPIQ scores between the groups over the study. However, they did find that emergency department visits and hospitalizations were reduced in the intervention group.
Dr. Julie Bynum wrote an editorial commenting on these 2 studies. She discusses the importance of the complexity of comprehensive dementia care and emphasizes the need for continued research in this area with specific considerations for different subgroups like patients with later stage disease. Let's listen to an interview with Dr. Bynum discussing the significance of these 2 studies.
So one of the keys, I think, moving forward is seeing what health systems do and really hoping and pushing them to be learning health systems, to study what they do. Let's not just rely on the overarching CMMI evaluation, which will evaluate the program in total, but let's try to get some energy around understanding what's going on in each individual practice and what's working. Because, to be honest, I think sometimes localized health systems, they know their service needs and communities better than us who sit designing trials that get deployed across multiple places. And so I think those insights are going to be critical to move forward.
JAMA also published a randomized phase 3 trial by Dr. Ignatiadis and colleagues in triple-negative breast cancer. The investigators assessed whether adding immune therapy to standard post-surgery chemotherapy increases invasive disease-free survival for patients with stage 2 or stage 3 triple-negative breast cancer. The investigators enrolled just under 2,200 patients who were randomly assigned to receive immunotherapy with atezolizumab with chemotherapy or standard chemotherapy alone. The authors found that the addition of atezolizumab to postoperative chemotherapy was not effective in patients with triple-negative breast cancer who are at high risk of developing metastases. The trial was stopped following planned early interim and futility analysis.
Doctors Hunter and Hurwitz wrote the editorial that accompanies this trial. They explain more about immunotherapy and what this trial could mean for clinical practice. They also discuss what makes atezolizumab different from other immunotherapies like pembrolizumab that have shown more promise.
JAMA also published a research letter by Dr. Jones and colleagues addressing the racial and ethnic disparities in home health use at the end of life for people with Medicare Advantage. They identified nearly 1.8 million decedents, dividing them into those who had Medicare Advantage versus traditional Medicare. Then they compared end-of-life home health use and duration between the two populations. The authors concluded that end-of-life home health use and duration were lower among Medicare Advantage than traditional Medicare for nearly all populations, and particularly for Hispanic and Asian or Pacific Islander decedents.
JAMA has a viewpoint this week from Doctors Tanvir and Ioannidis. They review the U.S. Food and Drug Administration's recent proposal to remove oral phenylephrine as an active ingredient in over-the-counter cold products and speculate on what this could mean for regulating other products that may lack demonstrable effectiveness.
For JAMA's clinical content this week, there's a review on essential thrombocythemia with a related podcast. Dr. Teferi and colleagues offer a comprehensive guide for diagnosing and treating this myeloproliferative neoplasm. Let's listen to Dr. Teferi review the symptoms of essential thrombocythemia.
I usually look at symptoms of essential thrombocythemia in two classes. One would be life-threatening symptoms, and this includes thrombosis and hemorrhage. And the other ones, I generally refer to them as being non-life-threatening, even though they're quite annoying when you have them. And this includes microvascular symptoms, which is an umbrella term that includes migraine headaches, for example, lightheadedness, painful sensation of the fingers and toes, atypical angina-like chest discomforts, and some patients, about 10%, might have palpable splenomegaly. Now, these symptoms occur in around a third of the patients when they present with their disease, and usually do not portend any more serious complications that are forthcoming. But the life-threatening ones, thrombosis and hemorrhage, that might occur in about 10 to 20% of patients, either at diagnosis or after diagnosis, are actually the real reason why we treat these patients with essential thrombocythemia.
JAMA also published a clinical challenge about a patient presenting with chronic urticaria, fever, and joint pain. And Dr. Schweppe and colleagues wrote a JAMA Insight about molecular phenotyping with proteomics. They review what proteomes are and the utility of clinical proteomics. The topic of this week's patient page is bedbugs. This resource could help patients and clinicians understand the signs and symptoms of a bedbug infestation, treatment of skin reactions, and bedbug eradication methods.
JAMA published several medical news articles this week. First, Associate Managing Editor Kate Schweitzer highlights current trends in bariatric surgery given increased usage of weight loss drugs. And in our AI and clinical practice interview, JAMA Plus AI Editor-in-Chief Dr. Perlis speaks with Dr. Linos, the director of the Stanford Center for Digital Health. Tune in to the Associated podcast to listen to them discuss patient satisfaction with AI-generated responses to questions in the electronic health record. Finally, freelance journalist Anna Bach wrote an article about the new CDC recommendations for avian influenza A, subtype H5N1 infection, also known as bird flu. The guidance includes recommendations for clinicians, laboratories, and the public. It also advises subtyping all influenza A virus positive specimens from hospitalized patients on an accelerated basis.
Thanks for tuning in to hear what's new at JAMA this week. These highlights were brought to you by Dr. Preeti Malani and me, Dr. Kirsten Bibbins-Domingo. This episode was produced by Shelley Steffens and Dr. Krista Roberts at the JAMA Network. A link to this JAMA content can be found in the episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. And thank you for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.